Good evening, everyone. Thank you for joining us tonight. Welcome to the Evexia webinar series. Our topic for tonight is Upgrade to UTI Testing. My name is Joanne Iverson. I am the Director of Client Relations for Evexia Diagnostics and will be your host for this evening. Today, I have the distinct pleasure of being joined by our guest, Dr. Elizabeth Seymour, who will be our presenter for this webinar. Dr. Seymour was raised in Denton, Texas, where she attended Ryan High School and then went on to receive her bachelor's at Texas Women's University. She obtained her medical diploma from St. Matthew's University School of Medicine on Grand Cayman Island and completed her residency at Oklahoma University Health Sciences Center. Dr. Seymour is board certified in family medicine and also holds a master's degree in health services administration. She currently works as a physician at the Environmental Health Center of Dallas and as a medical consultant for Real-Time Laboratories in Carrollton, Texas. Joining Dr. Seymour tonight will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Evexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, just a bit of housekeeping. We encourage participation. So if you have a question, you may submit your question in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. Without further delay, I will now turn the webinar over to Dr. Seymour.
Thank you. Hi, everyone. Hope you're having a good day. So I'm going to be talking about upgrades to UTI testing. I am, again, Dr. Elizabeth Seymour. I also wanted to say I'm board certified through functional medicine through the Institute of Functional Medicine. So I do practice a lot of integrative care in functional medicine and environmental medicine. But I'm happy to be a consultant for Real-Time Lab. Okay, so we'll first start off with what is a UTI. Now, many of you are probably physicians or practitioners or providers, but this is for anybody out there that doesn't know what a UTI or urinary tract is. It's an infection in any part of the urinary system, including the kidneys, the ureters, the bladder, or the urethra. And most infections are going to occur in the lower urinary tract, which is commonly the bladder or the urethra, which is why some patients will tell you, I feel like I have a bladder infection or I have a urinary tract infection. Women are at greater risk compared to men for developing these types of conditions, and we'll talk about that. So what causes a UTI? What happens when UTIs develop is microbes, including bacteria or funguses, enter into the urinary tract, and they start to replicate and proliferate and multiply. And then that subsequently causes an infection, which causes a lot of inflammation and pain and symptoms that occur within the GU system, which is the genital urinary system. Bacteria are the most common causes of UTIs, and fungal infections are another pathogen that can cause UTIs, not as commonly, but still a possibility. So let's get into some UTI statistics. Urinary tract infections are the most common outpatient infection with a lifetime incidence of 50 to 60% in adult women. Approximately 10 in 25 women and 3 in 25 males will have UTI symptoms during their lifetime. The prevalence of the UTI increases with age, specifically in women that are over the age of 65. That amount usually doubles in rate for the females developing UTIs. And a lot of that is postulated that it could be due to women going through menopause and having hormonal changes and lack of estrogen, which can change the vaginal and urinary mucosa, which would increase the risk of bacteria seeding there and developing urinary tract symptoms. In younger women, they are usually having increased sexual activity, and that's a major risk factor for UTIs and for recurrence that can occur within 6 months. It's not uncommon. I generally call this honeymoonitis. When our patients get married, they go on their honeymoon and they call me needing an antibiotic because they have a new onset UTI infection. We also have healthcare associated UTIs that are common forms of health acquired or healthcare acquired infections. There are large global surveys that indicate that the nature of the pathogens are going to vary between a community outpatient presentation versus like a hospital setting or a long-term care setting or a nursing home. The reason we're concerned about this is UTIs create a significant societal and personal burden, and they have a substantial number of medical visits in the United States every year being related to this. So what are the common UTI symptoms? Most commonly, you're going to start with symptoms of pain or discomfort and burning when you're urinating. That is what I put in the parentheses as the medical term dysuria. They could also have increased frequency of urination, which would mean they could go like 6 times in an hour even. That's called polyuria. They may have a feeling of needing to urinate, but not being able to empty their bladder. So that's the symptom of urgency. And then the urine may change colors. It could be bloody, and it would go from a normal yellow straw type color to a brown or a dark or a red color, which is called hematuria. In this scenario, especially with menstruating females, you'd have to make sure that they're not on their menstrual cycle. Obviously, that could increase the risk of blood in your urine. And then the pain type symptoms will usually be a characteristic of pressure or cramping sensation. It usually occurs in the groin or the lower abdominal area. So you may have abdominal bloating, you may have abdominal pain, but it's not in the upper quadrants of the abdomen. It's usually in the lower quadrants or in the pelvis, which would be pelvic pain. The characteristics of UTIs include that UTI is going to occur quickly. So it's an acute onset that can occur within hours or even days. And as you wait and you don't get treated, the severity starts to worsen, where you start to get more symptomatic. You may develop fevers, you may develop diarrhea, you may develop nausea, you may develop vomiting, you may develop new onset blood in your urine. And that's where the changes in the urine color come. And obviously, if you're a male and you have yellow straw urine and it starts to turn brown or dark red or bright red with blood, then that's not normal and you need to get that evaluated. And these can range. Obviously, they can be something like a simple UTI where especially your female patients, if they've had them before, they're going to call you and say, hey, I've got a UTI, can you call me something in? Or if you don't get them treated, or if you've never had one before and you don't get it evaluated and treated, it can progress to a serious kidney infection, which is called pyelonephritis. Pyelonephritis can be extremely serious, requiring hospitalization, IV antibiotics, and days within the hospital. So what's our differential diagnosis? If someone comes to you and says it hurts or it burns or I have discomfort when I urinate, the first thing you're going to think of high on your differential is going to be the thing that's most common, which is a UTI, urinary tract infection. But there are other things within your differential diagnosis that you'd have to consider. Those include fungal infections like possible candida. You could have a patient that has something called interstitial cystitis or IC, which is common where your patients will have UTI symptoms of burning or frequency or pain in their pelvis, but their urinalysis or their urine cultures come back negative. So there's no growth and there's no microbe that's identified or isolated. So in that scenario, as a practitioner, you'd really have to question, well, why would I prescribe this person an antibiotic if there's no microbe that's been identified? The next would be possible bacterial vaginosis, which is an imbalance within the bacterial flora. And then there could be an incidence of STDs, or now termed STIs, sexually transmitted diseases or sexually transmitted infections. Those could include herpes, which would burn and hurt, chlamydia and gonorrhea, which can be asymptomatic, trichomonas, which can cause a foul, fishy smell and a vaginal discharge, and possible pelvic pain. And then worst case scenario is bladder cancer, and that's not uncommon for a patient to have hematuria or blood in their urine, and they're asymptomatic. They don't have pelvic pain. So for physicians and providers, what are the current standards that you do to evaluate a patient that has UTI symptoms? Well, obviously, you're going to do a clinical history. With that history, you're going to ask them, when did their symptoms start? Have they taken anything to make it better? Cranberry juice, azo pills. And then you're going to want to do a physical exam if this is within the office visit, and look at their pelvis and feel their abdomen and make sure they don't have tenderness, make sure they don't have CVA tenderness, which would be a concern for pyelonephritis. And then your gold standard is going to be a diagnostic test, which would include a urinalysis, excuse me, a urinalysis, which would look at for leukocytes, nitrates, and or blood in the urine. And that's usually done by a urine strip or urine dipstick. Then if it is positive for that, you can at that point prescribe an antibiotic, or you can do even more and send it off for a urine culture. And you'd hope that they would have a clean catch, which I'm going to talk about in the future. But the urine culture would identify what type of microbe is growing on the culture. And then at that point, the lab would generally reflex and do urine sensitivity testing to make sure that you don't have an antibiotic that you prescribe that would be resistant to that specific bacteria that grew on culture. So let's talk a little bit more about the gold standard. The gold standard is diagnosing a patient with the UTI is going to be from a urinalysis and then from a urine culture, which isolates that microbe. A urine culture needs to be done midstream, and that's the hope that you obtain a clean catch. But urine cultures are not always performed, especially if you're in a primary care setting or an urgent care, or even the emergency department where diagnosis of UTIs occurs the most. But it is considered the gold standard. If the urine culture is not done through midstream and they didn't wipe well and sanitize their urethra well, then you can have a contaminated catch, which would show multiple microbial organisms. And then it's hard to know, well, is this E. coli or is this staph or is this strep, or and it's hard to know exactly what type of antibiotic to put them on as well. So the problem with urine culture is it is a slow process. We have to wait for the culture to grow and for the bacteria to replicate. That usually requires at least 24 to 48, sometimes even 72 hours before you'll get your results in. Once the causative organism is identified, then they will usually test for antibiotic resistance. And you come up with a problem if you put them on, let's say, macrobid, and it's an E. coli infection, and then it's resistant to the macrobid. Then you've got to call the patient and tell them, hey, we need to change it to a different antibiotic that is more sensitive to help kill the bacteria. At this point, when patients have infections, those infections can progress if the antibiotic is not sufficient, and you have to call them, and the hope is that you get a hold of them and that they do go get the antibiotic from their pharmacy quickly. So they'll be unwell, and most of the time your practitioners and physicians are going to prescribe an antibiotic just because the patient doesn't feel well, they're symptomatic, they're coming to see you, they're expecting to get some type of medication to provide relief, and they usually don't want to wait for a culture up to 42 hours. So what are the problems with your current gold standard? Well, first off, let's start with the COVID pandemic. When COVID occurred, we were granted access to provide telephone and telemedicine and virtual visits for our patients. I will say it has revolutionized my practice, and I can easily do mental health appointments and refill on medications and review lab results. But when it comes to an acute problem or an acute diagnosis, I really have problems with lack and limitations of doing an examination. I also have problems where I can't really get diagnostic testing quickly. So if someone had strep throat, I can look in their throat. They may not have pustules. They may have a red throat, but that could easily be a viral pharyngitis. And so I'd have to use my guessing and say, well, maybe this is strep throat. Maybe they need an antibiotic like amoxicillin without any rapid strep testing, without any throat culture performed. So there are limitations to telemedicine, but I do acknowledge that it is a very convenient process for patients and for practitioners. So what happens if you have a negative urinalysis? What if their urinalysis doesn't show leukocytes, nitrates, or blood? That would be a concern that the patient may have a symptom or a condition like interstitial cystitis. What if your culture is contaminated or dirty? So I've already brought that up. What if you have multiple microbials on your culture? How do you know which one is actually causing the infection, which one is most prominent in number? And then from there, if they do antibiotic sensitivity testing, how do you know which one to target? So again, we are all MDs, nurse practitioners, physician's assistants. We've gone through med school and nursing school and PA school, and we have had pharmacology. So we know what types of antibiotic classes we want to use, but ultimately we are using an educated guess of what type of antibiotic we should choose, unless there's a reason the patient can't take that antibiotic, like a sensitivity or an allergy or an anaphylaxis to that antibiotic. When and if you do choose the wrong antibiotic, or we don't isolate what type of bacterial infection it is, then you're going to be at risk for worsening the bacterial resistance. And then we have to go into the process of changing antibiotics. And that goes back to calling the patient. Sometimes their voicemail's full. Sometimes they don't answer. Sometimes they don't get notification from the pharmacy or the doctor's office that the antibiotic was changed, or why, or maybe they don't want to go pay for another antibiotic. So frustration begins to occur. And when you're changing antibiotics, you're going to increase the risk of bacterial resistance. And ultimately, we're going to have delays in care. When you have delays in care, there's going to be a worsening risk of just having what we call a simple UTI. UTIs, if they progress in the GU system, including up in the ureters and the kidneys, you can get a condition called pyelonephritis, which I talked about, which requires hospitalization. Worst case scenario, they start to develop sepsis from the UTI, which is called urosepsis. If you have seniors or a geriatric population, they may develop delirium, where they literally start to lose their mind and they're, out of their mind. And it's not because they're demented, but it could be from the actual sepsis or infection that's causing them to have their delirium state, which leads to more complications, higher risk of falls, longer hospitalizations, more medications, and it's just a worse outcome in the future. So the topic is, how do we upgrade our UTI testing? Well, the most common ways that people and animal get contaminated this slide is not correct, but the most common way that we've decided to test for UTIs is through real-time lab. We've developed a PCR test that is more specific, and it will test for multiple different microbes that can cause UTIs. One of the other things that I want to talk about on this slide is that mycotoxins can also be a reflex test that is tested through urine and through real-time labs. So if you have a patient that has a known mold exposure and there's a concern that the mold could be producing a mycotoxin that humans can be exposed to that could cause toxicity in the human body, those mycotoxins come out of their body specifically through their urine. And also through stool and skin, but we have a test that will test for mycotoxins. And I do want to point out, if you have a patient that has GU symptoms, pelvic pain, abdominal pain, urinary tract symptoms, burning, hematuria, dysuria, polyuria, urgency, you would want to rule out that, especially if you have a UA or urine culture that's negative, you'd want to make sure that they don't have a toxin in their bladder and in their urine that's being detoxified, such as a mycotoxin. Okay, mycotoxins are going to be, patients are going to be exposed to mycotoxins through inhalation and dermal absorption when they're exposed to mold. And usually mycotoxins will grow in buildings, either your workplace or your home, that have had water damage and received some type of flooding. There are other studies that suggest that you can get mycotoxin poisoning specifically from aflatoxin by consuming contaminated food or drink. All right, so the features of our real-time PCR UTI test, the reasons why we're recommending you do this is it would reduce the false negatives that occur with UTIs, or with UAs and with cultures. What we're going to do is detect many microorganisms in the same sample, and there is a possibility that you could have polymicrobial or multiple pathogens that are causing this. We will also include genetic testing. That's a panel that indicates if there's any resistant genes that are present. And then for the practitioners and the providers and the physicians, if you've never done a PCR UTI test and you don't know what these genetic results and genetic testing mean, we have myself as a physician and a nurse that is available to help with consultation so that you'll understand what antimicrobial choice you should use. And the other part of this is that our reporting occurs within 24 to 48 hours. So if you have a patient come in your office at 8 a.m. and you can get those results by the next day or within that evening, that's going to improve your care with the patient. It's going to improve your ratings, and your patient's going to think that you're the better doctor because you got the results and you communicated those with them and you treated them in an efficient manner. All right, so what are the benefits, again, to review of why we should do PCR UTI testing through real-time lab? First off, it's going to provide rapid and accurate, and it's a targeted molecular diagnostic test for the pathogens that are causing UTIs. It's going to eliminate guesswork in diagnosing and treating UTIs. And the difference between a urinalysis and a urine culture is real-time lab is using PCR molecular technology, which is considered a more advanced test. The next is that it detects 98 to 99% of bacterial and fungal targets. It's going to reduce the guesswork of what type of medication you should use, specifically antibiotics. And it's going to reduce the delays in diagnosis. When you reduce those delays in diagnosis, you're also going to reduce the delays in treatment and ultimately long-term and short-term reduce the risk of complications like pyelonephritis or urosepsis. So this is the list of the bacteria targets that we test on our PCR UTI test. There's common ones that I'll list for you: Citrobacter, Enterobacter, Enterococcus, E. coli, Klebsiella, Morganella, Proteus, Pseudomonas, Staph, Strep. Those are the different ones that we're going to be testing for bacteria. Then we move on to our yeast and fungi. So commonly, women especially will get Candida albicans, which is a yeast infection. And I do want to note that there are other types of Candida out there, specifically Candida glabrata is something that's becoming more of a concern as a pathogen. And we can do reflex testing if you want to test for yeast and you want to reflex and test for Candida glabrata, we can do that as well. And then this gives you the list of the different types of genetic testing that we're doing. So specifically, if you're looking for a macrolide antibiotic resistance, we're going to be checking the 23S rRNA, adenine methyltransferase ERM-B, that is a loaded description or title. And I'm not going to go through every single one of those, but just realize that we can test for macrolide, beta-lactam, glycopeptide, quinolone, and sulfonamide genetic resistance through this type of testing. And from that information, that's where you would decide, okay, I'm not going to use Bactrim, or I'm not going to use a Cipro, or I'm not going to use a nitrofurtone or macrobid. So how do you start testing your patients for this? Well, you need to call or order the test kits. Those test kits will be sent to your office, and then you give that urine cup to your patient and they submit their urine sample. There's a requisition form that is accompanying the urine test kits, and you yourself, your staff, or your lab person would fill out that requisition form, decide if you just want UTI testing, the reflex testing for possible Candida glabrata, and then also if you want to do a urine mycotoxin test. You'll send that specimen to real-time lab. It will be shipped overnight. And then the importance of that, especially with weather changes. Right now we're in winter time, but in Texas, especially here at Real-Time Lab in all of Texas, we can get 110, even as high as 110s or even 120s. And that is a concern when you have super cold or super hot weather, that the urine culture may not be able to test because it can disintegrate or denature. And with DNA testing, it can withstand multiple ranges of temperature. So whether you're in, upstate Maine or New York or the north and they're super cold, -0 freezing, or if you're in Arizona, New Mexico, Texas, and we have 110 plus degrees, the DNA is not going to denature, and we can still test for that. It's only if it's boiling would we worry about denaturation with the DNA testing. And then just to reassess and reaffirm that we are testing for the lowest level of detection, and that's obtained through DNA testing. So when the DNA is present, not only are you going to receive a positive result, but your sensitivity of the testing goes up significantly. So let's get back to the final thing that we were discussing, is the resistance to antimicrobial and antifungals. Real-Time Lab is addressing the antibiotic resistance in the organisms that are causing the UTIs, excuse me, by doing this specific type of PCR testing and with doing the genetic testing that we do. We feel that this is a public health crisis based on the number of patients that have UTIs and the amount of visits that go to primary care offices, OBGYNs, urgent cares, ERs, hospitals, nursing homes, long-term assisted or LTACs. Many of those patients are experiencing patients that have UTIs. And the other thing that is coming across is there are antibiotic stewardship programs that are being implemented through hospitals and through nursing homes and LTACs, and even physicians themselves are being graded on how often they send antibiotics and then what types of antibiotics. So we're really trying to focus on reduction of antibiotics if they're not indicated, and use of antifungals more if they are indicated. But again, you may have resistance to certain antifungals if we're using those not judiciously. So this is just improving, again, the judiciousness of our use and choice of antibiotics, more targeted, and hopefully preventing delays in care and serious complications like pyelonephritis or urosepsis. These are my references if you'd like to look them up and read them. And now we'll go to any questions that you have, and hopefully I can answer them.
Wonderful. Thank you so much, Dr. Seymour. We do have a few questions, and if anybody still wants to go ahead and put any other questions in, we certainly have enough time to go over and answer those questions. First question that I see on here: how do you test best for intestinal cystis?
You mean interstitial cystitis?
Interstitial cystitis, yes, thank you.
Unfortunately, there isn't what I would say a gold standard test for IC. There are many things that can cause IC. What you have to do as a diagnostician is rule out that they don't have a urinary tract infection or bladder cancer or a yeast infection or an STI. But there is no gold standard test to say definitively you have interstitial cystitis. That is more of a clinical diagnosis based on multiple negative UTI results, multiple negative cultures. You could even do pelvic ultrasounds, CAT scans, and the patient is still coming in with UTI symptoms. So yeah, there isn't a good test. I will say at the Environmental Health Center Dallas, where we do allergy testing for molds and foods and anything, pollens, dog hair, cat hair. And foods can also be a source of why a patient would have interstitial cystitis. So if they can identify what that variable is and avoid it, then they're less likely to have the IC symptoms. But if they can't, we do allergy testing on the skin at our practice, and we can give insight to the patient to know if they're allergic to whatever the highly allergenic foods are: gluten, dairy, corn, sugar. And then, it could be something that's not a highly allergenic type of food. It could be, something as common as chicken or spinach or tomatoes, or hard to say. So we try to help the patient figure out that variable.
Thanks. All right. Here's another one. Please elaborate about how best to go about frequent urination at night. Do you prioritize your inquiry?
So frequent, urinary frequency, specifically at night, generally is not a UTI symptom. You can have multiple conditions that could cause nocturia, which is the nighttime urinary frequency. Specifically in males, if they have prostatic enlargement, then they may wake up multiple times a night because they have pressure on their bladder and their nervous system is telling their brain to wake up to go urinate. And they have possible obstruction or decreased flow because of that prostatic hypertrophy. They could also be on blood pressure medicines, possibly like a diuretic, which would cause them to urinate more. So there's a different type of workup if they're specifically having nocturia or nighttime urination only at night. But it's not to say that if a patient had a UTI that they may wake up, if they got symptoms at 3 p.m. in the afternoon, I wouldn't be surprised if they said, I had to wake up 6 times that night to go urinate. And then they see me the next morning and they say, I'm still urinating every hour on the hour, or I'm dribbling, or I'm not going, or now my urine has blood. That's when you'd start to correlate nocturia.
Mm-hmm. Thank you. All right, a few more questions. What is the turnaround time with results?
24 to 48 hours. Usually less than a day, but just, we don't want to put it out there that we can guarantee we'll give it to you in less than 24 hours. So it's within a range of 24 to 48 hours.
Is this a quantitative DNA test?
No, it's a qualitative DNA test. So we're basically testing to see, is it positive for that specific pathogen's DNA, or the antibiotic gene resistance, is that positive? It does not tell you that you have, for instance, if E. coli on a urine culture was like 10,000 particles or 10,000 specimen pieces, it wouldn't quantify that for you on this test. So whatever is in the urine, especially if we're testing its DNA, if it's positive, it's positive. And if it's a pathogen that we're testing, like E. coli, which should not be in the urinary tract, then if it's positive, it's positive. And that's why you're going to go with that specific type of treatment with an antibiotic based on the genetic testing. But no, that's the difference with culture versus PCR testing. We're testing DNA, and it can be a very small amount of DNA that could come back positive. And you only need one bacteria in a matter of time before it replicates enough to cause the symptoms. So I hope that answers it.
Thanks, Dr. Seymour. I really only have one other one that I see remaining left in here. What is happening in the urosepsis exactly?
So urosepsis means that it occurs from a urinary tract infection. The urethra is the most closest to the outer portion of your body, whether you're a male or a female, within your vagina or your penis. That's where you're urinating out of. That's the hole that the urine comes out of. If there's a bacteria that enters within that, it will move up from your urethra into your bladder. And that's where, especially with women or even men, you'll start to have pelvic pain in your lower abdomen and pelvic area. If the bacteria continues to replicate and progress, it will go up the tubes, which is called your ureters, 2 tubes that connect to your kidneys. And then if your kidneys get infected, you are usually sicker than a dog, and you have fevers, and you'll have a lot of different systemic symptoms. So you may have fevers, chills, nausea, vomiting, diarrhea, back pain where your kidneys are, abdominal pain, pelvic pain, and you are sick. So you usually have to go to the ER. You have to be admitted into the hospital. You have to have IV fluids for making sure that your blood pressure is stable. So when you get a diagnosis of sepsis, especially with bacterial sepsis, the bacteria is an infection in and of itself, but it produces a toxin, and that toxin causes sepsis, and it's from the urinary tract that is causing that infection. So anybody can get sepsis from any infection. It could be from pneumonia, it could be from meningitis in your cerebral spinal fluid, in your brain, it could be from a cut in your skin, it could be a joint infection, it could be a bladder infection. But when you get sepsis, the risk of morbidity and mortality goes up significantly, even including ICU admission. So you're very sick, you have toxins, you have an inflammation, you have an infection, you need high dose, strong, atomic bomb type antibiotics to wipe it out. You need pressors, which are usually Levophed and other types of epinephrine and norepinephrine type supports that keep your blood pressure up, because when you get sepsis, depending on what type it is, it can cause your blood pressure to drop. You won't have perfusion. You can have multi-organ failure. It's just a very bad diagnosis, a serious diagnosis, and it can be deadly. So just remember, urosepsis, increased morbidity and mortality from something as simple as a UTI.
Thank you. Now that we've learned about the UTI test, we are looking forward to the launch of Real-Time Laboratories UTI test. In the meantime, of course, practitioners can always access real-time diagnostics testing and a wide variety of testing right on our test menu. So they'll be able to place those orders and order that. Can you move to the next slide, please?
Okay.
All right, I just want to go over a few other services with Evexia for our practitioners here. I want to remind everybody about the feature we have, Ask the Doctor, with Dr. Wayne Sedano. 2 options with this. It's a free email consultation right on your Evexia account on the left-hand side, where you can go in and ask any specific questions. As you have any results back on your Evexia account, Dr. Sedano will review that right in that Ask the Doctor section. We also do have an area for a live consultation, and you can find that information on the left-hand side under your Ask the Doctor. Next slide, please. And then for any questions or questions you have, you can contact Evexia Diagnostics by email at info@evexiadiagnostics.com or by phone 5 days a week at our extended hours, 8 a.m. to 8 p.m. Eastern Standard Time at 888-852-2723. We will have a recording of this webinar, which will be available by email in the next few days. And I think that's the last of the slide, I believe. Do we want Dr. Sedano to weigh in or make a comment or anything from the presentation? Dr. Sedano, you're on.
Yeah, I'm here. Dr. Seymour, thank you so much. Yeah, I just want to make a comment and maybe see your take on it too, Doc, about the relationship between interstitial cystitis and autoimmune disease. That's something that maybe some of the clinicians may want to check out, do an anti-nuclear antibody. I know there's been an association with Sjogren's disease, so that may be something that they want to, consider that as well. Because when I've treated patients with that condition, all else fails, I'm looking to regulate the immune system, going after the GI tract, checking for anti-nuclear antibodies, on that, just because it can be very, very daunting thing to an individual.
Of course, yeah. I mean, we see quite a few IC patients, unfortunately, and by the time they see us at our office, they've usually seen multiple physicians, had tens of thousands, if not hundreds of thousands of medical workup, including lab and diagnostic and hospitalizations and ER visits and multiple trials of medications. And like I said, there's not a real specific or gold standard diagnostic test, but if it's a food allergy or if it's a chemical or if it's a toxin or if it's a bacteria, you have to kind of put on your Sherlock Holmes hat and really investigate and dig deeper on what could be causing their symptoms. And I agree with Dr. Solano's assessment that you want to check the immune system. We do that standardly every day in our office and see many patients. I would say 50% of our patients have an ANA that's positive. So that keys you that there is some type of abnormal immune response that could lead to Sjogren's or lupus or rheumatoid arthritis or polymyalgia rheumatica or some type of autoimmune condition. And it's possible it could target the GU area, it could target the bladder or the urethra that could be causing their symptoms. I don't have any studies or ways to prove that just yet, but as I said, we always want to dig deeper and try to make sure that we're doing the best for our patients and doing a thorough evaluation and see if there's a correlation there.
Yeah, anecdotally, just last comment on that, I've had some patients that have lived next to gasoline stations and toxic. You're an environmentalist, so I think I'm sure you get what I'm talking about. Just those organic compounds, whatever. So I would encourage anyone, if the patients do present with interstitial cystitis, do a wonderful, a very extensive environmental toxin history in their home, work, what's in their town. I found it to be very beneficial, but I'll end it there. Thank you so much.
Yeah, when I got into functional medicine, I was doing a lot of inflammatory markers, and I learned from inflammation that there's only 4 categories that cause inflammation, and IC could be potentially a chronic inflammation of the bladder. So it's either a trauma, like you got punched in the gut, or you had a surgery, or you had a baby. It could be allergies. It could be infections, which is what we're ruling out with this test, or lastly, it could be toxins. And I really had to focus on toxins because there's a multitude of toxins in your environment that you could be exposed to that could be causing it. Gasoline, mycotoxins, heavy metals, VOCs, we could go on and on and on. So you do want to, again, make sure you're ruling that out and making sure you're not missing something.
Thank you so much. Wonderful presentation, Doc. Thank you.
You're welcome.
Yep. Thank you so much. So thank you again, everybody, for joining us for this webinar event. Until next time, from everyone at Evexia Diagnostics and Real Time Laboratories, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Good night, everybody, and thank you.